The topic that we are going to touch today is red eye. This is a very important topic, in the sense that red eyes are probably seen more by the family physicians than by the ophthalmologists in the first instance. Before we actually start the topic, just a quick revision. Why red eye? What causes the redness in the eye? The answer is just one: inflammation. From where here we lead to the second point. What are the causes of inflammation in the eye? It is the same good old list of causes, triggers of inflammation, which would be noxious substances secreted by bacteria, viruses, fungi, protozoa. Then another cause due to ischemia, then another cause due to mechanical trauma. So all of these noxious agents trigger a mechanism of initiation of the inflammation, which involves neurotransmitters, prostaglandins, leukotrienes. So it is basically one same process of triggering of inflammation in the eyes, which causes the appearance of red eyes. In clinical practice, what are the causes of red eye? Well, this is just a brief presentation, just as an example of what we saw. Patient came with redness, watering, grittiness, stickiness in the morning, and there was no other history of ocular trauma or any other associated medical condition. The other eye was normal, and the examination of the affected eye, left eye, showed all the features of inflammation. The important point is that the visual acuity remained 6/6. The second most important point is that there is no corneal staining. The intraocular pressure is 12, well within normal limits. The anterior chamber is again quiet, indicating no inflammatory activity inside the eyes. Rest of the examination revealed a normal eye basically. So the clinical diagnosis is acute conjunctivitis, very straightforward. This is the type of patients I think everybody would love to see, because the treatment is very simple and the response is very good. The patient is very happy. So, what are the causes of red eye? There are many, but to summarize them, basically the first and the commonest cause is acute conjunctivitis. The second is acute keratitis. Third, acute anterior uveitis. Fourth is acute congestive glaucoma. This is what we were taught as a list of causes of red eye, and I would like to stick to this list, knowing fairly well that subconjunctival collection of blood or a localized patch of episcleritis or scleritis would still make the eye red, but I find it hard to include those in the causes of red eye when we are primarily dealing with the red, which is associated with inflammation. This type of redness which is there just because there was a rupture of a small capillary, subconjunctival capillary, and caused the red eye, very alarming picture for the patient, is of practically no sequence to the eye, generally requires no treatment. A patient with hypertension, a female patient with long nails, patient with a history of a minor trauma, even cough, straining, sneezing. If one of these categories of patient comes to the clinic with sudden development of red eye with no real pain, no discharge, no effect on the visual acuity, there is about 100% chance that it is subconjunctival hemorrhage. Easily visible without any magnification with simple torchlight, diagnosis is fairly simple, and the treatment is straightforward. In the first instance, for the first episode, we just reassure the patient, inform him or her what has happened, and tell him that this is not serious. So we do not require any special investigations for the first time. No special treatment is required for this. If this thing becomes habitual, becomes recurrent, then we need to investigate for the bleeding problems, platelet counts and partial thromboplastin time. And of course, try to treat if any abnormality is found. Even then, in almost all of these cases, the inside of the eye is normal, so the visually important structures are not affected, and there is no visual complaint or risk to the vision. So from the ophthalmologist's point of view, a subconjunctival hemorrhage is probably the most benign type of red eye, not even included in the list at the moment. Let's see what is there. A little more elaborate. In infections, it can be bacterial and viral, in fact fungal, protozoal also, and in allergies, simple allergies or giant papillary type, vernal catarrh type of allergies, sometimes associated with contact lens wear as well, and chemical allergies, all sorts of toxic or noxious chemicals, acids, alkalis, or physically abrasive chemicals, they can cause inflammation and result in a red eye. And of course, a foreign body lodged on the cornea or in the conjunctival sac can produce a red eye. This is a photograph of inside of a lower lid, indicating the follicular pattern. This would be seen with some magnification, preferably with the help of a slit lamp. This is an example of an eye having fungal keratitis. The corneal substance is involved, the whole of the cornea is hazy, and there is a horizontal fluid level in the anterior chamber. This is pus hypopyon, very serious condition. Relatively milder form of keratitis in which the rest of the cornea is clear, but there is an area of haziness, basically a localized interstitial type of keratitis. Staining pattern is specific in some forms of keratitis, and herpetic keratitis is one of those. There are few dendrites coming out of the main stained area. Acute uveitis, but By just looking at this diagram, all you can see is that there is some redness and the cornea is probably not shining as beautifully as it should. We can't just diagnose acute uveitis by having a look at this eye alone. But we can't miss the diagnosis if we have a look at this eye as well. There are pigments on the surface of the lens. There are posterior synechiae, which are the abnormal adhesions of the iris and the anterior capsule of the lens. So if you see this type of picture, there can be no other diagnosis than uveitis resulting in posterior synechia. If you look at this peripheral cornea and the appearance of the iris, it would be obvious that there has been a closure of the angle of the eye. The iris, peripheral iris, has bowed forwards and is now in contact with the cornea, occluding the angle and raising the pressure, resulting in the condition called acute congestive glaucoma, also called acute narrow angle glaucoma. So how do we manage? I believe if we take a careful history, we should be able to differentiate between a patient who can be treated in the family physician's clinic and a patient who needs to be referred urgently for specialist care. Even before examination, just on history. This is so because the symptoms of the patients, they are quite specific. The most common form of or common cause of red eye would be simple bacterial conjunctivitis. The symptoms in this case would include redness, discharge from the eyes, gritty feeling, and very importantly, stickiness in the morning. While asking for the history, we will also ask for the nature of the discharge. If the discharge is purulent or mucopurulent, then it is bacterial infection. If discharge is clear or watery, then it is either viral or allergic in nature. So the nature of the discharge also gives a fair clue to the etiology. In the history or presenting complaint, just while we are chatting with the patient, we will ask whether the vision has gone down or is it just about the same as it was before the redness set in. In case of conjunctivitis for any cause, whether it is bacterial or fungal or viral, whatever, or allergic, the visual acuity would be normal. At worst, the only effect on the vision will be a very transient blurring when a small piece of mucus passes in front of the visual axis, and then with the next blink it becomes clear again. So basically, the patient would say that no, I'm in a lot of pain and discomfort, but my vision is fine. This is the only category which can be treated in the family physician's clinic. The other three causes of red eye, which included acute congestive glaucoma, acute anterior uveitis, and acute keratitis. These three categories, they need specialist care, either by a specialist or by a family physician who has received some training and is using some form of magnifying devices and intraocular pressure measuring gadgets. So a little bit of specialist clinic is required, whether it is actually done by an eye specialist or by a family physician trained in ophthalmology. So this is why I elaborated so much on the history, that I believe that with careful history alone we can differentiate between the patient to be treated by yourself and the patient who probably needs a referral. Next comes the clinical examination, all important. This would include the tests of vision, diffuse light examination to see any puffiness, swelling, grade the redness, look for any discharge, matting of the eyelashes, all these, pupillary light reflex, fundal glow, all of these things will be seen here. And of course, measurement of intraocular pressure and staining of any suspected lesion with the help of 2% fluorescein dye. So once we perform these tests systematically, there is simply no way that we can miss the diagnosis. It is absolutely just not possible. Investigations, generally we do not require any investigations for the initial diagnosis of the disease. The investigations are done only to refine or pinpoint the cause of that particular inflammation. For example, if it is bacterial keratitis, that will be diagnosed on the clinical examination alone, and further investigations of culture and sensitivity will only pinpoint as to which particular agent is involved. Most of the times we don't even require that. So this is in the history. Stickiness of the eyes after sleep and associated symptoms like pain, itching, watering, reduction in vision, photophobia, colored halos around the lights. Each of these has its own importance, you see. Stickiness points very, very strongly to the presence of bacterial conjunctivitis, simple conjunctivitis. Pain, itching and watering, these group of common symptoms don't mean anything. Reduction of vision is the all important parameter, that if the patient is very vehement that no, my vision is being reduced with this redness, don't sit home, ask the patient to go to a specialist. If there is redness and decreased vision, this is a killer combination. This is not to be missed. Redness with normal vision and the patient says, I can see quite well, there is no effect on the vision, that's fine. You can treat with topical antibiotics. But patient with reduced vision and redness, this is a bit serious business. Similarly, the symptom of photophobia, that the patient when he goes out in the bright light is disturbed by it, that is also important. It is present to some extent in keratitis, to a very, very mild extent in conjunctivitis, but is very prominent in anterior uveitis. So a very big indicator of intraocular inflammation. Presence of colored halos around the light. Colored halos can be produced either by corneal edema, when the cornea swells up and loses part of its transparency, so that the normal white light which is passing through is now being scattered into its component parts. So patient sees colored halos around the bulbs and tubes. If it is present without the red red eye, then it indicates that this scattering effect is taking place probably somewhere else, not on the cornea, most probably within the lens itself, and pointing to the presence of very early cataracts. But if it is present in a patient with a red eye with a prominent symptom of pain, reduction in vision, redness and colored halos, there can be but only one diagnosis, that is acute congestive glaucoma, in which case, out of the severity of the symptoms, the most severe symptom would be pain in the eye. Pain sometimes can be so severe that the patient will have sympathetic vomiting associated with it. As we are coming close to the holy month of Ramzan, at the time of breaking of our fast, we sometimes tend to overload ourselves with fluid suddenly, 3 or 4 glasses of water. This is one mechanism which can induce or trigger the acute attack of narrow angle glaucoma. So you are likely to see a few of these patients in the next month. Middle-aged to old patients who were fasting, and about half an hour after the iftari, they start having heaviness, pain in the eye, and then reduced vision. On digital examination, the intraocular pressure will be very high. So this will be a typical patient with narrow angle glaucoma. There is a high association of hypermetropic type of refractive error with these patients. So if you are still in doubt, have a look at the glasses. You will find that the patient is using plus lenses, plus glasses even for distance. Of course, we will ask for any similar attacks in the past. Things like uveitis and recurrent attacks of acute congestive glaucoma, they are not uncommon. So we can find a history of similar attacks in the past, and of course we can have a clue as to the diagnosis of the cause in the previous episodes. If there was the previous episode was diagnosed as acute congestive glaucoma, most likely this one is also the same. Any ocular trauma, surgery, or any drops which have recently been instilled in the eye, they can cause redness and pain in the eye through different mechanisms, one of which is allergic reaction, the other is induction of surgical or traumatic inflammation. Most of the times, you say multiple combination of antibiotic drops, out of which neomycin is particularly notorious, and similarly polymyxin drops. I have actually stopped using these combination drops because once we instill these drops and we are facing a patient with red eye, but then we don't know which particular component of these multiple antibiotic drops the patient is allergic to. So he is doomed not to be able to use those drops for the rest of his life. So the best thing is to use single antibiotic at a time. Systemic diseases that can cause redness, there is no systemic disease that will cause redness on its own. It will cause redness through the one of the mechanisms involved. Generally, the autoimmune problems, they have multi-system inflammatory problems, and diseases like rheumatoid arthritis, SLE, and any other autoimmune phenomena, they will have localized or diffuse episcleral or scleral inflammation causing episcleritis and scleritis. Otherwise, in their own right, the systemic diseases do not affect. In examination of the eyes, an important point to be noticed is the pattern of redness, whether the redness is more marked around the cornea in the circumcorneal region or whether it is more marked away from the circumcorneal region, that is the forniceal region within the fornices. Generally, infective conjunctivitis causes more redness peripherally in the fornix, whereas in cases of uveitis, keratitis and acute congestive glaucoma, all of these three, the redness is more marked around the cornea. This is called ciliary type of congestion. In this, the individual vessels of the conjunctiva may not be discernible very clearly and there is a purplish hue, whereas in the dilated typical conjunctivitis redness, the individual vessels of the conjunctiva are easily visible. It is easier to divide this sort of distinction and perhaps practical in the initial stages, but once the whole of the conjunctiva is extremely red, then I think this particular finding is of no use to determine whether it is simple conjunctivitis or whether it is one of the other three. Simple conjunctivitis I have divided as the group to be treated by yourself and the other three to be treated, to be referred basically. So these circumcorneal type of congestion, if you can recognize, it is good. Otherwise, depend on the symptom of no reduction in the vision. If there is reduction in the vision or photophobia or very severe pain, then again this is a case to refer. Intraocular pressure measurement is of course a direct test which will give you an immediate answer if you are suspecting whether this redness is due to glaucoma or not. In cases of glaucoma causing redness in the eyes, the pressure will be very, very high, way above 20. It will be as high as 40 or 60 or 70, something like that. So just can't miss. A pressure of any borderline pressure of 20, 25, 30, this would not cause acutely red eye. See, if the eye is markedly red and the pressure is barely 22, then rest assured that this is not due to acute congestive glaucoma, although this patient coincidentally might be having a slightly higher than normal intraocular pressures. The pressure which would cause red eye has to be very high, something above 30. Well, these examinations are to be done by the eye specialist, so I'm not going in a lot of detail. Generally, a hazy cornea is a diseased cornea, which the haze can be focal or it can be diffuse. Examination of pupil is important because it does not require any special gadgets. A pupil which is shiny, normal colored, bright, in which the crypts are easily visible, and a pupil which reacts to light briskly, that is a normal pupil. On the other hand, a pupil which is mid-dilated, vertically oval, non-reacting to light is a pupil in a case having acute congestive glaucoma. A vertically oval, mid-dilated, non-reacting pupil points to acute congestive glaucoma. A pupil which is very small in an eye presenting as a red eye and in a patient complaining of photophobia and slight reduction in vision is a pupil in an inflamed eye, acute anterior uveitis. Confirm the presence or absence of any discontinuity in the corneal epithelium. Normally, the epithelium is covered with tears, and fluorescein is a water-soluble dye. It stains the tears but not the surface of the cornea. The corneal surface is made up of lipid-rich cell membranes. If these membranes are intact, then fluorescein cannot stain these. If these membranes are broken, then the inside of the cells is exposed. This environment is again aqueous and this is stained with fluorescein. Anyway, it's very simple to perform and doesn't require a big instrument. You can keep your fluorescein either in solution form or safer still in strip forms, fluorescein strips. You just touch the conjunctiva with a yellow fluorescein strip and ask the patient to blink a few times and examine with ordinary torch. You should be able to see the yellowish stain if there is any corneal ulcer. These are the final treatment guidelines. Patients with conjunctivitis may be treated by using topical antibiotics or anti-allergic medications as required, or any supportive medications like analgesics. And patients with keratitis, uveitis and glaucoma, they need specialist care. What are the common medications used? Topical antibiotics for infections, topical anti-allergies and mast cell stabilizers for allergies, topical pilocarpine and other anti-glaucoma medications, and oral Diamox for glaucoma, and topical antibiotics and mydriatics for keratitis. Topical steroids and cycloplegics for anterior uveitis. So basically, these are the broad outline of the medications used in different disorders of red eye. The difficulty in devising a universal treatment for all red eyes is that there is simply no universal treatment. The reasons are that the topical steroids are the mainstay of treatment of anterior uveitis, but they are absolutely contraindicated in keratitis or corneal ulcers. The patient will have very similar symptoms, very similar presentation, red eye, reduced vision, pain. One patient requires steroid as the first line of mainstay treatment. Without steroid, the treatment would fail, because this is the mainstay of the treatment. And if by mistake we put these steroids in a case of herpetic ulcer or any other bacterial corneal ulcer, then we'll make sure that the eye is doomed. The eye which would otherwise probably have healed without any treatment is not going to make it this way. topical steroids are going to reduce the local immunity, reduce the rate of healing, and both of these things combined, they give a free hand to the noxious agent, which can divide and then simply eat its way through the substance of the cornea and cause perforation within hours, and of course permanent loss of eye. Similarly, the second example, in case of narrow angle glaucoma, pilocarpine drops are required to make the pupil small and to open the angle. They work quite well, but if we put these same drops in cases of uveitis, imagine what will happen. In uveitis, there is a lot of inflammation in the uveal tissue, including the iris. The surface of the iris is coated with fibrinous, thick coat of exudates. Now, if you put pilocarpine on top of that, the pupil will become small, and come in firm contact with the anterior capsule of the lens, resulting in dense adhesion formations or dense posterior synechia formations. So a bad practice to put pilocarpine in case of uveitis. Similarly, if we put mydriatic or atropine in case of narrow angle glaucoma, it will make the angle go further closed, and if the initial attack of narrow angle glaucoma was mild, we will make this attack full blown by dilating the iris and pupil and causing the angle to go further narrow and then to close completely. So the same group of medicines are indicated in one disease and contraindicated in the other. So this is where the seriousness of this relatively simple and common red eye, this thing lies. Unless we are sure of the diagnosis, we cannot give the appropriate treatment. This is what will happen if we start giving atropine to everybody, or pilocarpine to everybody, or steroids to everybody. Some people will be benefited, of course, but the others will be doomed. So what do? It is just simply impossible to suggest a universal treatment for all red eye patients. So this is what I have tried to do, to suggest a group of safe medicines while you are in doubt and the patient is in waiting time. This is what we can do in all cases of red eye. Of course, if we are sure that the diagnosis is merely conjunctivitis, the patient doesn't need to be referred. But if there is any doubt, you can start with topical antibiotics, start systemic analgesics, systemic diamox, topical lubricating agents, and topical beta blockers. This will take care of many of these things. Of course, not treat them appropriately, but will give them a breathing time until the specialist can see and suggest an appropriate treatment. So this is important. These are the artificial tears type drops, like tears natural. There are lots of lubricating agents available. Tears natural 2 from Alcon, fresh eyes, eye wet, but a lot of drops. The common mistakes which I have observed, which are being done everywhere, that is, the use of pilocarpine or cycloplegics is very rare, fortunately, but the topical use of steroids, inappropriate topical use of steroids, remains a threat even today. It is being used very commonly for all types of red eyes, and this can be dangerous. I think this is it. Thank you. Any question?